Okay, so I'm going to be prompt today so that we have plenty of time to hear from our speaker. So I actually have the pleasure today of introducing Raj Daftary, who will be speaking about the under 5 mortality rate. Raj is the current medical director for the pediatric emergency medicine room department at the SFGH, so Zuckerberg San Francisco General Hospital. And on a personal note, we've had an opportunity to work together both here at Mission Bay in San Francisco, as well as in Dar es Salaam, Tanzania. So really looking forward to this talk today. And as I said, we have both our residents on, as well as several members from around the global community. So with that, Raj, I'll let you take it away.
Sounds great. Thank you, Teresa. Let me go ahead and share my screen and see. Okay, and I'm going to put this into presenter mode and we'll see if this works out. Okay, fantastic. Can everyone see this?
Yes.
Okay. Thank you for being here and thank you for the invite. I am really excited to present this topic. This is, I think, a good representation of the way that I like to think, just big picture. And that's really what we're going to be focusing on today. I think when we think about death in children under the age of 5, it's a really difficult topic. And especially when we think about just the vast magnitude of the challenge that's in front of us, it is somewhat overwhelming. But I think there's important reasons to be optimistic, and we're going to spend some time talking about that. If we have enough time, then what I might ask someone to do at some point is to share their screen, because we're going to do an exercise. We actually have 2 exercises, which hopefully will be engaging. But if there's a volunteer, if someone's thinking about it, I might ask that in a later session. And what I will tell you is that I am totally guilty of putting way too many slides in this presentation. And so rather than zooming through this like I normally do, I might just skip a couple slides. But as questions come up, I actually appreciate being interrupted, especially because I can't always see the chat. So please stop me at any point for questions around clarification, or if there's anything that you want to just talk more about.
And Raj, I can keep track of the chat for you too, so don't worry about it.
Oh, that'd be great. Yeah, and just interrupt me whenever. Thanks, Teresa. It must be said, I have no disclosures. And then just to give you a little bit of my background. So I finished residency in, I think I've got someone unmuted.
Asya, Asya, can you mute, please?
There's a Zoom superpower I now have. You can mute people, which I just figured out, which is really cool. Anyway, so my background. So I finished residency in 2008, and between 2008 and 2010, I worked as a pediatric hospitalist in the country of Lesotho. If you aren't familiar with Lesotho, it is one of the few landlocked countries that's surrounded by one other country, and that's South Africa. And it has approximately a population of about 2 million, and it has the 3rd highest prevalence of HIV amongst their general population. And so my focus was on caring for children who were HIV infected, but also I was seeing children with malaria and malnutrition and other infectious causes which account for a major burden of disease and cause of mortality in children under 5, which we'll also talk about. I came back in 2010, finished my fellowship, and then have shortly thereafter started working at UCSF. As I mentioned before, in my emergency medicine kind of perspective, I'm looking at the larger picture, and this will be less focused on particular causes of death, but that is something that I hope through this global health series, you'll have the opportunity to discuss and think more about. So our major objectives for this discussion will be essentially looking at the major causes of mortality, looking at global initiatives to reduce that mortality, specifically the Millennium Developmental Goals and the Sustainable Developmental Goals. We'll talk about the current progress in mortality reduction and kind of identify those causes, domestic and international. And then the hopeful part, we'll talk about the interventions. So before we go any further, let's just define it. So under 5 mortality means the probability that a child will die by their 5th birthday per 1,000 live births. And the reason that we choose under 5 versus over 5 is that worldwide, under 5 deaths tend to fall into a couple buckets. They tend to be from prematurity or intrapartum related events or infectious causes, whereas over 5 cause of death tends to be largely from injury, accident and injury. And as a whole, what we've seen since we started recording this in the 19th century is dramatic decreases in mortality. And most of those reductions have come from advances in science and technology, from improved standards of living and public health campaigns, such as clean water and sanitation. Now, under 5 mortality was, in spite of this progress from the 19th century, there was still a large burden of death by mid-century in the 20th century. There was significant progress made between 1960 and 1990, and largely that was in areas where there was still high burden of death, and that was in the developing world. And so by 1990, we had achieved a mortality rate, an under 5 mortality rate of approximately 93 per thousand. The absolute number of what that means is about 12 million. So 12 million children died before their 5th birthday in the year 1990. And there were large inequities between low and middle income countries versus high income countries. In 1990, the world came together and they set a goal to reduce mortality to about 70 per thousand, or about 1/3 by region. This was a 10-year goal. And it was on the surface level, had they maintained that trend in reduction from 1960 to 1990 onwards, they would have met that target. But what was an annual reduction by 2.5% essentially slowed down to about 1.1%, and they did not meet target. So in 2000, the global community came together through the United Nations, and they actually came together with a really powerful statement that, and I'm going to read this word for word: every individual has a right to dignity, freedom, equality, and a basic standard of living that includes freedom from hunger and violence and encourages tolerance and solidarity. This is what we aspire for in a global community, that we're looking out for each other, that the well-being of every citizen from all countries is regarded equally. So to operationalize that, there were 8 developmental goals that were produced and released. And specifically for children, there was Millennium Development Goal number 4. And that articulated that between 1990 and 2015, so again, they're already they're using the 1990 number, and this is being developed in 2002. So they're giving themselves less than 15 years to reduce child mortality by 2/3. And they wanted to hit that target they want to take it from 93 per thousand to about 31 per thousand. And what this actually required was that they were going to have to reduce mortality by about 4.4% annually. And think about that. So between 1960 and 1990, they had at best a 2.5%. And between 1990 and 2000, it dropped to 1.1. So they were going to say that they were going to reduce mortality. That reduction, they were going to quadruple their success rate, right? So that is an enormous endeavor. And this was a global community saying that we're going to take action and we're going to make a significant difference in reducing the number of children that were going to die before their 5th birthday, right? So using 2008 numbers loosely, what we know is that there's a very significant burden of disease or death in low and middle income countries versus high income countries. In low and LMICs, where a child was 18 times more likely to die before the age of 5 compared to high income countries. And we know that there were some core countries that accounted for the vast majority of deaths. And actually this number we'll talk about, it's actually even just less than a dozen that accounted for a very large number of under 5 deaths. But essentially 42 countries accounted for 90% of deaths worldwide. If you look at each of these dots, each dot represents, in the year 2000, 5,000 dots, okay? And not being able to see the chat, if anyone wants to put it in the chat box, maybe I'll try to pull the chat box in a second. But, oh, I can see it now. Feel free to use the chat box because I can see it now. But can you tell me, what are the regions that you're seeing large numbers of mortality? Where's the red concentrated? Can anyone name those countries or the countries that fall within those regions? I see India, Nigeria, Pakistan, right? So sub-Saharan Africa, sorry, South Asia, which includes India, Pakistan, Afghanistan, and then also Western Africa and Eastern Africa. So Nigeria, Ghana, Ethiopia, Sudan. Sudan actually is not marked here, but specifically Ethiopia and Kenya and Tanzania account for large absolute numbers of deaths. And in 2008, these were the target countries that were identified, and the yellow were countries that were added because they still had opportunities for improvement. So what I want to show you is essentially two side-by-side tables, right? And two ways to think about this problem. So on the left-hand side, you have the countries, and this is in 2000, the countries with the 5 highest numbers of absolute deaths: India, Nigeria, China, Pakistan, and the DRC. And on the right side, you'll see the countries with the highest probability of death per 1,000. So in Sierra Leone, for example, it was 316 per 1,000, right? That means 3 in 10 children were dying before the age of 5. Okay, so again, using the chat box, or feel free to unmute yourself. What is a trend that you see in the left? How can you explain that? And then how can you explain it maybe on the right side? The right side might be a little bit harder to do, but tell me, what do you think the differences are between these two groups? Are there any, actually specifically, are there commonalities between the countries on the left and the countries on the right? I'll give it like 10 seconds. Right, so left, absolute population size, right? Thank you, Prachi. So India is very populated. China is very populated, right? Billion plus population, and Nigeria as well. So if you think about, even if their overall mortality rates were somewhat lower, the fact that they have a higher overall population is going to suggest that there is going to be a large number of absolute deaths. So if a country was developing a policy to reduce mortality, that country is going to have a larger impact and overall global reduction in number of child mortality if they are successful. On the right side, you have to think back to 2000, what might have been going on in these regions in 2000, but can you surmise any similarities between these? Right, conflict. Thank you, Teresa. So this is where there was political instability and conflict, especially around the turn of the century, okay? And unfortunately, some of these countries are still experiencing conflict and unrest. When we think about the impact that has, that destabilizes the health system, there's injury from violence, there are many downstream impacts from the conflict that results in impaired health systems and increased mortality. So let's get to the conclusion of this, or what was the upshot. So was MDG4 successful? So remember, their goal was to bring it down to 31 per 1,000. Hugely ambitious goal, right? They didn't meet that goal. They only hit 43 per 1,000. But let's consider that they took it from, in 1990, 93 per 1,000 to 43 per 1,000. That was an overall reduction rate of about 53%. And the absolute number of deaths that were saved, or the children that were saved, were about 4 million fewer deaths per year in 2015 compared to 2000. There was wide success in sub-Saharan Africa. There was wide success in Asia. Sub-Saharan Africa actually had a 2-fold increase in the reduction rate. So about 3 million fewer deaths in 2015. And Asia experienced a 50% overall increase in reduction rates. So significant improvement in 2 areas where there was very high burden of disease. And yet there's still room to go. So if we draw a comparison between 2000 and 2017, remember those countries, the top 5 countries that accounted for absolute numbers of deaths, you'll see that China has actually dropped off of this. And countries such as India, Pakistan, and the DRC all experienced major reductions in overall mortality. I don't quite know the nuances of Nigeria and its challenges around this, but unfortunately, their overall reduction rate was somewhat limited. As a whole, the trend between 1990 and 2019 is that we moved from 12.4 million deaths to the latest number that we have, 5.1 million deaths. If there was an area or a population that was slow to have a decrease in mortality reduction, that would be in neonatal mortality. So if you look at this, so this is kind of a color-coded map that will show you, this is the situation in 2015, and it talks about deaths per 1,000 live births. The darker colors, the reds, show you where there's still very high rates of mortality. And so you'll see that here, Sudan and Mali now have very high rates of mortality, with as high as 120 to 140 per 1,000. So again, that's still that number of 1 in 10 children will die before the age of 5. You see improvement in India, some improvement in Afghanistan, and then Nigeria still has a very high overall rate of mortality. But can everyone see the cursor when I move it around? I just want to know if it's useful or not.
Yes, we can see it.
Oh, perfect. Okay, then I will keep it off screen until I need it. Okay, so let's focus now. I'm going to shift gears on causes of mortality. So essentially in 2015, there were about 5.9 million deaths. And we can break them down almost evenly between the neonatal period versus the postnatal period, right? So 1 to 59 months versus the first month of life. And there's a difference in terms of the major causes. In 1 month and later, it tends to largely be from infectious causes. So pneumonia, diarrhea, or malaria, and then injuries does have a part to play in this. In the neonatal period, there is an infectious cause. Sepsis is a major cause of death, but by and large, most of the death was occurring from either prematurity and related complications or intrapartum related events that really resulted in death within the first 1 week of life. Thinking about those major causes of death, we're going to take one step back and just look at trends again. So if we started, so as of 2000, remember I mentioned that we had hit right at 2000 when they were working on the MDGs, the under 5 mortality was about 78 per thousand, and we got down to about 43 per thousand. So the way they did that was essentially, if you look at the green bars, these are the causes of death where there was the most significant reduction, and that accounted for the overall number. This is kind of the number per thousand deaths that were reduced. So 6 per thousand, 6 per thousand, 433. That's where there was major progress made. And that was in areas such as pneumonia and diarrhea, malaria and measles, so infectious causes, but also intrapartum related deaths were reduced. And we'll talk about kind of some interventions, some simple interventions, low cost, low tech, that had significant improvements in survival for children who were otherwise dying shortly after birth. This is another way of looking at a challenge. And so the challenge here is we have to recognize that the cause of death, again, varies between particular countries that have a high burden of disease and death versus those that have lower. And so this is an interesting graph, and essentially it's two side-by-side graphs, and on your y-axis is something called the Socio-Demographic Index. And what that's looking at is households, regional household income, education, and fertility, with those with the lowest attainment of those things being at the lowest end of the scale versus those at the highest, with the ideal being 1 and the lowest being 0. And each one of these colors represents a particular cause of death. So I'm going to take the orange color, which is going to be diarrhea. And if you'll see, so those regions on the lower SDI scale had a higher absolute number. So the left side of the graph represents absolute numbers of death, and the right side represents proportion of death for the number of deaths that they had. So you'll see that not only was there a high number of absolute deaths in the low SDI regions, but there was also that diarrhea comprised a high proportion of deaths, about between 15 and 20% by estimate for these countries. And then if you move up the SDI scale, you'll see, not surprisingly, causes of death from diarrhea tends to be from an absolute number, almost 0 as you move past 0.75. And as a proportion, it also accounts for very little cause of death. The most likely cause of death as you move up into the upper SDI regions and countries is largely from injury or congenital abnormality. So, and this is a nice summary of it. So, and this is, I think, a really important thing to consider, is that the countries that we had already identified where under 5 mortality was very high, so 7 countries accounted for 20% of overall deaths. And in that particular block, it was infectious pneumonia, malaria, and diarrhea. As you moved into that next block between medium and high rates of mortality, that overall number is about 63. And excuse me, I think it's 73. 73 countries accounted for about 60 to 70% of total deaths. And here we start to see not only pneumonia, but then we start to see neonatal causes of death, so preterm birth and intrapartum related events. Whereas if you move into those countries, now there's about 114 countries with low and very low mortality. And then we start to see congenital abnormalities and injuries become more common causes of death, as opposed to the infectious causes that we saw in those countries that had very high rates of under 5 mortality. So I'm going to show you two tables. I'm going to show you them up front. And then essentially what this is doing is these are two very colorful charts that are showing you causes of death and how they account for the proportion within each country. And so this is showing you in 2015, the 10 countries with the highest rate of overall mortality in children under the age of 5. And note that they're all countries in Africa. If you look at the major causes of death, again, it's pneumonia and diarrhea, and then some with preterm complications. And then if you see that red bar accounts for malaria. Note that malaria, as it's recorded, accounts for very small proportion of deaths in Somalia compared to, for example, Sierra Leone, or Mali, where it counts between 20 and 24% of overall deaths. Okay, so the take-home point here is it's largely infectious, and there are some preterm birth-related complications that account for about 10% in most areas. HIV accounts for about 10 to 15% in these regions, sometimes a little bit higher depending on country. Now compare that to the 10 countries with the highest rates of, sorry, not the rates, but the highest absolute number. Again, these are two ways to look at this challenge. So the highest absolute number of mortality. And you'll note that the major causes now tend to be from preterm birth complications, pneumonia, and intrapartum related events. The African countries of Nigeria, the DRC, and Angola still have malaria. And then other conditions also account for a large proportion. But here again, the point being that it's not only infectious anymore in these countries, it's also prematurity and complications around that. Questions so far? I think we're doing okay. All right. So let's compare these two key areas. So we're going to look at Southeast Asia and we're going to look at Africa. So this is using 2010 numbers, but you'll see that the colors are slightly different. You'll see that neonatal deaths in Southeast Asia account for 52% of deaths, whereas in Africa, they only account for 30% of deaths. Africa has a higher number of overall deaths. And so what this is a result of is that those infectious causes still account for a disproportionate or a higher burden of death or cause of death as compared to countries in Southeast Asia. And sorry, the important point to take behind this is that one solution is not necessarily going to target every country's needs, that the interventions need to be tailored to the specific burden of disease within each country and within each region. Okay. Now I want to talk about malnutrition. So malnutrition is something that's very close to my heart. And that largely comes from my clinical experience working in Lesotho, where I would approximate 30 to 40%, probably actually higher, of my hospitalized children had at least some degree of malnutrition. And most of them were moderate to severely malnourished. And I think one of the reasons why it holds a special place in my heart is because most of the children who died on the hospital ward had some level of malnutrition upon presentation. And it's incredibly frustrating to treat malnutrition in that you can have a child who shows improvement and is gaining weight, and they can have rapid decline within just a couple of days. And so it's, from a provider standpoint, it was something that was very difficult to care for. Malnutrition is no longer reported as a direct cause of death, but it is implicated in approximately 53% of all deaths. We know that if you're mildly malnourished, it doubles your risk of death. If you're moderate to severely malnourished, it increases your risk of death between 5 and 8-fold compared to someone who has no degree of malnutrition. And we know that at least some nutrition is implicated in 50 to 60% of deaths from diarrhea, malaria, pneumonia, and measles. So as we're thinking about these specific causes, one thing to consider, and we'll talk about this as we talk about interventions, is what role does treatment of malnutrition play in all this, or even preventing malnutrition in improving survival? Now, I'm going to shift gears again, and we're going to talk about neonatal mortality for just a minute and just focus on it. So one thing to be clear is in 2008, using those numbers, it accounted for about 41% of total under 5 mortality. And if we think about this, what this says is that your first 28 days of life are riskier than your next 1,800 days of life. You have a 30-fold increase of death during that short period of time compared to the rest of your under 5 lifetime. 99% of neonatal deaths were occurring in low and middle income countries, and your greatest risk of death is occurring in the first 24 hours in these countries. This is the cause of death that had the slowest rate of decline as we were reducing overall mortality. And there's large implications between the health of the newborn and the health of the mother. Maternal mortality still accounted for about 500 deaths per year in 2008. And the lifetime risk of a mother dying in childbirth was 1 in 10 in some regions, meaning 1 in 10 women in some regions were their cause of death was going to be from childbirth, from not necessarily a single pregnancy, but at some point during any pregnancy, their overall risk of death is going to be 1 in 10. If we look at the causes of neonatal mortality, so intrapartum events, specifically ischemic injury, and then also prematurity and poor survival from that. There is a role for infection with an impaired immune system or non-robust immune system. And so pneumonia and sepsis has a major place to play. And then there were some birth practices that have changed, but tetanus was also a cause of neonatal mortality. Does anyone have an idea why tetanus was a cause for neonatal mortality? I'll give it like 10 seconds in the chat. Right, so cutting the umbilical cord and stool on the umbilical stump. So there were birth practices in place, traditional birth practices in place, or there was lack of access to sterile equipment so that the umbilical stump was becoming infected. And that was the point of entry for tetanus infections. And so there was a practice of placing stool or mud, thinking that it was a protective barrier when in fact it was seeding infection. Another implication is that I mentioned that maternal mortality has a really important role to play. So the health of the mother, her ability to care for and nurse her child, but also maternal mortality or maternal health has impacts on intrauterine growth restriction, on a child being small for gestational age. And that in turn has an impact on premature birth. And that also has an impact on survival and ultimate nutritional status when a child gets older. So all of those have also been linked to neonatal mortality. And this is a really interesting slide. And what it shows us is that in that first week, your risk of death per 1,000 survivors was significantly higher in the first 48 hours compared to the last, like the 27th to 28th day. And even that first week, we can see this is where there's a very high proportion of mortality, signaling that this might be an area where intervention could be especially effective if there was going to be an intervention. Finally, let's just talk about how does the United States compare to this? So I think that's important as we bring it into our local context. So under 5 mortality, as was reported in 2018, was approximately 6.5 per 1,000 live births per UNICEF. If we look at, this is a CDC slide that dates back to 2017. But if we look, so unintentional injury was a major cause of death for ages 1 and over. So the first time that you start to see an infectious cause, especially in less than 1, is down here, number 7, bacterial sepsis. There's also prematurity that's linked to it, maternal pregnancy complications. But if we compare this, especially the 1 to 5, we can see that unintentional injury, malignant neoplasms, and congenital anomalies, and also death by injury by homicide were major causes of death, as opposed to the infectious causes that we were seeing in low and middle income countries. If we just look at the under 5 mortality rate in 2011, you'll see that that number is 7.1 compared to worldwide, which was 52.8. But I think importantly, I think something that's somewhat humbling is that our numbers in the United States in 2011 were still higher than compared to the rest of what we would consider the developed world, which was 6.6 per 1,000. So we had the Millennium Developmental Goals. In 2015, we know that they didn't quite hit the mark of what they were shooting for. They brought it down to about 43 per 1,000. And then this got transitioned into something called the Sustainable Developmental Goals. And I think the really important thing behind MDG was it showed that with collective action, there could be significant improvements in child survival and reducing under 5 mortality. So much so that this goal is incredibly ambitious. And what it is saying is that we are going to end preventable deaths of newborns and children under the age of 5 by 2030, right? So they're not saying we're going to end all death in children under the age of 5, right? That's not necessarily practical because of congenital abnormalities and other causes of death. But what it says is that we can bring down those preventable causes to about 25 per 1,000 live births. And for neonatal death specifically, we can bring that down to about 12 per 1,000 live births. So how do we get there? So let's talk about interventions. We've got about half an hour left. And this is the first exercise. So what I'm going to do is I'm about to flash a table. Okay. And what I want you to do is think about this and grab a piece of paper and a pen and just write down what you think would be causes or particular interventions for a cause of death. So on the x-axis, you'll see major causes of mortality. On the y-axis are going to be some proposed interventions. You can take a screenshot if that's another way that you want to work on it. But what I want you to do here, let me just go to that slide. So on the top, you'll see major causes of death. And on the far left, you'll see potential interventions. And I want you to pick at least 4, you can write it down for at least, pick 1 intervention for every significant cause of death that you see on the top of this table. And let's see if we can find one that works for every single one of them, okay? And I will give you a hint, there are some interventions that will be effective for more than 1 cause of death. All right, so why don't we take about, we'll take about 3 minutes for this. And I'm going to mute myself in the meantime. If you have any questions, feel free to ask now or put them in the chat. Well, you saw some of the answers, but let's keep doing it anyway. I'll give it about 1 more minute, okay? Okay, I'm going to go ahead and advance the slide. Before I do, can someone throw in the chat or unmute yourself and just tell me, if we were to pick, let's look at breastfeeding in particular. What causes of death do we think that exclusive breastfeeding is going to have an impact on? So diarrhea, okay. Pneumonia, okay. Diarrhea, pneumonia, sepsis. Okay, so infectious causes. Okay, great. Great, that's a great observation, Emily. And so you're now delving into why is exclusive breastfeeding especially helpful and how can it reduce death? And one of the major causes is that in formula administration or in other types of preparation other than breastfeeding, there's a risk for contaminated water and that being a cause for diarrheal illness. So great. Okay, so I'm going to go to the answer slide, which you saw. But breastfeeding, and this is based off studies in 2003, and subsequent to this, there's been evidence that suggests that it can be impactful in other things. But survival from diarrhea and pneumonia can be improved from exclusive breastfeeding, as can survival from neonatal sepsis, right? Which is all the ones that we listed. And then, interestingly, what I love about this table is what it shows us is that not only does one intervention work across multiple causes of death and underline the benefit of it, but also we can see that major causes of death also have other evidence-based interventions that can be impactful. So again, let's look at diarrhea. So breastfeeding, complementary feeding, water and sanitation improvements, zinc supplementation and vitamin A. We'll talk about that in just a little bit. But then also there are treatment interventions in addition to these preventative interventions, such as oral rehydration, antibiotics. And again, zinc comes up here too. So if we think about, especially from an infectious cause of death, diarrhea and pneumonia, you'll see that there are items here that suggest that there are multiple opportunities to reduce mortality. And that's one of the things I think is really exciting about this. And this doesn't include new interventions that have been developed, for example, neonatal resuscitation, so NRP and the widespread dissemination of that, the introduction of bubble CPAP, or positive pressure for premature infants. So there's even more opportunity to reduce death here. Now we're going to spend just a minute, or in a couple of minutes, we're going to go to this website if I have a willing volunteer. And there is a tool called the LiveSave tool, which has been developed out of Hopkins. But essentially what it is this is a conceptual framework. And what it will show you is on the left hand are interventions, in the middle are risk factors, and on the right hand are causes of death. And each box that has a little circle on the top right hand means that it can be expanded, and you can look in and it will subdivide kind of causes of maternal mortality, for example, or causes of stillbirth. Those arrows that you see have a causal relationship, right? So either it will result in death, or there is an intervention that will reduce the likelihood of that particular risk factor or ultimately death. Okay, so this is a really fantastic tool, and I'm going to take you to this website in just a little bit that we'll get a chance to play with. So if we think about exclusive breastfeeding, so again, to define exclusive breastfeeding, meaning between birth to 6 months, there is early initiation of breastfeeding within 1 hour post-delivery, and that is the only nutrition that is provided to a child. The target that we are aiming for is a target coverage per region of about 90%, understanding that not every mother will be able to provide breast milk or breastfeed their child for whatever reason that may be, right? But setting a target at 90%. And then also encouraging something like complementary breastfeeding, and that is that breastfeeding continues up until 24 months. So let's just look at the impact of breastfeeding. So if we did breastfeeding promotion and we did a maternal intervention, a newborn intervention with kangaroo mother care that's putting the child directly on the mother and early breastfeeding, we know that we could, first off, directly, if you look at the arrows in that risk factors, we know that we could directly reduce major causes of child mortality and neonatal mortality directly for those things that we already talked about. But then, as Emily pointed out, we could also reduce the incidence of diarrhea, right? So if we reduce the incidence of diarrhea, then that means that our overall nutritional status would be better, right? And that means that we'd have lower rates of stunting. Stunting is basically just long-term malnutrition, right? And as I mentioned before, the role of malnutrition, if it's implicated in about 53% of deaths, if we can reduce the burden of malnourished children within a country, or better rephrase of that. So if we can reduce the prevalence of malnutrition of children within a region, we know that survival will increase because their likelihood of dying from these infectious causes will decrease, right? So here's a really good demonstration of how a simple intervention with really high uptake can have multiple points of impact and reduce death from multiple causes from birth all the way to 5 years old. Okay, and this is something that I get really excited about, because there's no silver bullet for under 5 mortality, but there are some pretty good interventions that are going to have really high impact that, frankly, the cost for implementation is significantly less than other interventions, which might not have as much of an impact. Okay, and that's one of the other things to consider, is that as we're choosing interventions, which are the ones that are going to have the greatest likelihood of reducing child mortality. Let's talk about another one. And so we talked about the burden of malaria. And malaria is an interesting challenge in that what it does is not only does it cause death directly in children, but we also know that mothers who are infected with malaria during their pregnancy have a higher rate of maternal mortality. Also, their children have a higher likelihood of growth restriction and being born small gestational age. It increases your likelihood of maternal and fetal anemia, and increases your likelihood of death overall. And so if we provide an intervention, then we can hit all of these points whereby that has a downstream effect and leads to death. So what IPTP is intermittent preventive treatment in pregnancy. So just essentially providing at 3 scheduled times antimalarials to mothers in regions where malaria is endemic, regardless of whether that mother has an active malarial infection or an malarial infection at that time. We just know that if we provide just across the board treatment, we can have overall reduction. And again, the way this happens is, as I mentioned before, we reduce maternal mortality. We reduce the likelihood of them being born small for gestational age. And if they don't have that, then they're less likely to have overall malnutrition or stunting, which means that overall survival from infectious causes of death, again, increases. And then also it has a direct impact on stillbirths or children being not surviving within the first 24 hours of life. Finally, another intervention, so micronutrients. So we don't discuss this much in our regular pediatric practice domestically in terms of vitamin A supplementation and zinc supplementation. And that's simply because we don't have a lot of micronutrient deficiencies in the United States. But in other regions of the world where there's food insecurity, these are major opportunities for intervention, not only from a preventative standpoint, but also from a treatment standpoint. So just doing scheduled vitamin A dosing twice per year between 6 and 59 months, it reduces our likelihood or our incidence of diarrhea. And then also it can provide treatment, as I mentioned before. Zinc is also a mainstay of treatment for children with an acute diarrheal infection, and it reduces the total length of diarrhea and severity and improves survival. So this is the slide for vitamin A, and we can see how it has a direct impact on diarrheal reduction. It also reduces your diarrheal incidence, which again, not to belabor the point, but it also improves our overall nutritional status, which improves our survival from, again, these infectious causes. And zinc, pretty much in the same way, right? Decrease the incidence of diarrhea, improve stunting, or reduce the likelihood of stunting, improve our overall nutritional status, decrease pneumonia incidence. So again, also has multiple downstream effects. Okay, so this is something that I think also brings me a lot of hope. I think there's a lot to be excited about in that there are interventions that really can have an impact and make a really big difference in survival. So do I have a willing volunteer who's willing to open up their web browser and share it and work through this exercise with us? If not, you can do this individually, but it's way more fun to watch someone do it. How about this? Yeah. Would you be willing to volunteer?
Yeah, I can do it.
Okay, sounds good. So for everyone else, or actually, why don't you do this? We'll do this together, okay? I want you to type in this web address, listvisualizer.org, and when you've got it pulled up, let me know and I'll unshare my slides.
And Raj, as host, you may also have to give permission for her.
Oh, okay, sounds good. Let's see if we can figure this out.
While we're pulling that up, could I ask a quick question?
Yeah, go for it.
So in settings where malnutrition is happening to both like prenatally and then going into like once they've already given birth, is it like a proactive way to make sure that you're treating mom so that she's able to produce breast milk to feed baby versus like going to formula nutrition? Like what's the approach for like if the whole family or like the region is malnutrition and like a humanitarian crisis?
So there are programs such as the World Food Program, and I forget what the immediate eligibility is for it. So for example, in Lesotho, there was perversely, there was not that people were going out and getting infected with HIV, but if you had an HIV infected individual in your household, you automatically qualified for the World Food Program. And that means that you got food supplementation to your family. I believe that that program also applied to pregnant mothers. I don't know what the current status is on that, but there is a general thought about improving the health and the nutritional status of mothers and the downstream impact that might have on child survival. So that's a great question.
Thank you.
Okay, ready to share?
Yes.
Okay, all right, I'm gonna stop share. Okay. Oh, fantastic. Okay, cool. So what our challenge is going to be here is what I'd like you to do is I want you to help me understand what might be two key interventions between, if you had to choose between oral rehydration and zinc, not that we're always choosing, but if you had, let's say you had like $1 million, do you want to spend that money on oral rehydration solution, or do you want to spend it on zinc supplementation? So, and our target, my nonprofit, is very interested in, oh my gosh, you're already jumping ahead. Yes, exactly. So we're really interested in reducing death from diarrhea because that's foremost on our mind. So let's find the interventions, right, which you've already done, and then help me understand what's going to be more effective between zinc and ORS. So if you don't necessarily click on that, but if you click on between, that's zinc supplementation, there should be treatment. Yeah, there you go. If you click on that arrow to the right of that box, okay, and you click that number, what do you get? Right, so that's showing that the efficacy is about 0.23. So as I read that, that can reduce death from diarrhea about 23%, right? If you close that, and then if you click on, do we see oral rehydration solution? There you go. You click on that and you can see 0.93, right? So the efficacy is quite high for oral rehydration solution versus zinc supplementation. And I think, interestingly, they also report something, the affected fraction. So 88% of diarrhea will respond to oral rehydration solution. So that's something to factor in when you're choosing interventions. Well, what I will tell you is that this tool isn't necessarily the best way to pick out what's the best, most effective, and most feasible intervention. But what I do like about it is that it has this conceptual framework and it shows you all these interrelationships. Hand washing, excellent, right? So it's not the most effective, right? But it does decrease diarrheal incidence, and it's a bar of soap, right? It also means access to water. So the point behind all this is know that there are many interventions, and that there is an evidence base. There's a body of literature that we can refer to, and this is really nice to give us links to it that can show us how we can find meaningful interventions. The thing that's not taken into account of this intentionally is the cost per intervention. Okay. All right, I'm going to take over the slides again. Thank you so much for being a willing volunteer. And just to go through those steps again, the way you would do it is you would go to that website, you would click on causes of child mortality, and then it would send this up, and then you can click on diarrhea specifically, and then you can click on those arrows and you get two comparisons. Okay. Has anyone ever used this tool before? I'm just curious. I'm assuming not. But when I first saw this, I just got really excited. If you have some time, especially if we end early, try to play with it. I think there's a lot to be seen from this. Okay, so let's talk about interventions. What would it mean? So this is a study back in 2003. So this is dated, right? But if we looked at all these interventions, this is the same study that had that table that I showed you before. And this is basically making the argument that in an ideal world, if we could scale up to 99% coverage rate for all these interventions that we talked about, and none of these are very high cost interventions specifically, with the exception of water, sanitation, and hygiene. That would be a larger campaign, but essentially breastfeeding, providing zinc, clean delivery, ORS, antibiotics, providing the Haemophilus vaccine. Haemophilus influenza vaccine, all of these, if we had hit 99%, then we could have reduced 6.3 million deaths, right? And we would have easily achieved the MDG4, right? There is, my slides are stuck. If we look where coverage was in 2000, though, the only thing that was somewhat close was complementary breastfeeding, but that was only for 6 to 11 months. This doesn't take into account up to 24 months. Measles vaccine was low. Clean delivery, there's improvement. Everywhere there's room for improvement, but I think specifically where I see room for improvement was exclusive breastfeeding. It was at 39% coverage. So 39% of countries were meeting that target for that 90% goal. This is just looking at the continuum between pre-pregnancy and childhood, where there could be potential interventions. This is the same thing, and it's just talking about coverage rates in 2010. And you can see how coverage rates for a lot of the interventions after the neonatal period were lower compared to the immediate postnatal period. This is a slide that talks about coverage of breastfeeding specifically in Lesotho. And I think the important thing is showing, and this is again from a little while back, but it's showing that there were trends in improvement. So if you look at the third country on this table, so the area where I practice, Lesotho, looking at between 1996 and 2004, their exclusive breastfeeding rate went from 16% to 36%. And across the board, there was an improvement in all the countries that were studied here, showing that there's huge opportunity and that this is something that can be done. But even after these interventions and even 10 years later, in some of these comparisons, there was still room for improvement. So what does it cost to do all this, right? We sometimes think that, is it a matter of will? Is it a matter of funding? What does it take in order for us to implement such interventions? So in a study in 2005, looking only at cost, right, as the limiting factor, if we implemented 23 known effective interventions and we targeted 42 countries with the highest rates or accounting for the largest bulk of mortality, 90%, and we scheduled it into 18 scheduled contacts for mother and child, and we assumed 99% coverage. So a lot of ifs, right? A lot of caveats here, but in an ideal world, if we could implement a program, especially in a community health setting, what would it cost for us to do this? And essentially what it would cost annually for mortality reductions would be about $5.1 billion annually. 5.1 billion, okay? And we think about where our spending goes, and I'm not making a political argument here, but I do want us to take into account how our money is spent in this country and around the world, right? And again, recognizing that this is an ideal presentation, an ideal circumstance, this packaged intervention, assuming that it's going to be effective to the degree that they state it's going to be. What it's arguing, though, is that we could save a life with $887 spent per life saved per year, right? We think about the infrastructure plan that's going up for a vote. We think about where our spending priorities are. This would argue that this is not some astronomical number that is beyond our reach. It says that there is a number that is attainable that we can reach to save these children's lives. There's another study that was arguing the same point. If we just looked at providing interventions that we knew had an impact on pneumonia and diarrhea, what would it take to reduce causes or these causes of death, accounting for 2 million in 2013? Those known interventions, if we scale them just 80% coverage, right? Slightly higher cost here, but we could save about 1.4 million deaths, or sorry, we could avoid 1.4 million deaths with a total cost of $6.7 billion. So all this to say is that it is not some very large number. It's in the single digit billions, if that makes sense. It's in the 9-digit number, meaning that this is an attainable number that, that could be achieved from the global community. This slide is taken from a paper that essentially is looking at where can we provide interventions. It doesn't always have to be in the hospital. Sometimes it can be in the community or even within the household. So when childbirth happens at home, for example, providing early breastfeeding, providing immediate skin-to-skin contact, providing hygienic cord and skin care, this is something that can be done at the household and can have a significant impact on neonatal mortality. Right. And if we look at infancy and childhood, you'll see what's even more interesting is that all these interventions can happen, almost all can happen in the household. So this argues that the solution isn't necessarily we don't need to wait for entire hospital systems or health systems to be built up. The interventions can be achieved at multiple levels, including the household level. So now I'm going to put on my emergency medicine hat and just talk about, you're going to hear from Carol Chen during the next couple of weeks. You're going to hear from Nick Glom. You're going to hear, I think, hopefully, Teresa, you're talking about your amazing work too. But Teresa is not Pam. She's critical care, as you all know. But what I want to talk about and just focus on is just, if we think about a conceptual approach to reducing mortality, there's something called the 3 delays model. And the 3 delays model was specifically developed and applied for maternal mortality, identifying that there are 3 major causes of delay that result in death for women in childbirth. There is poor recognition that there is a life-threatening presentation within the community setting. There is difficulty in accessing health services, so in transport to the health system or the health facility. And then once they arrive at the health facility, there's a delay in providing care, whether that's because they're not recognized at that facility, or that system itself is overwhelmed, or that facility doesn't have the resources. So the interventions that are being provided by PEM faculty in particular is that delay in recognition of illness severity. So Carol's going to talk about nursing education and a curriculum that she's developed that's going to eventually feed down to community health workers to talk about early recognition and who should be transported to a health facility. Nick Glom is going to talk about the work that he's done in Botswana and how he has developed improved pre-hospital systems and emergency medical services. And then work that Teresa has participated in and that Nick have participated in is essentially in training emergency medicine trainees who have now become faculty in locations such as Tanzania and in Uganda. And then Carol's also going to talk about the basic emergency care course, which applies to this level as well. So all that's to say is that there are folks doing work and the work is truly impactful and that there's opportunities at essentially every single level. What I want to conclude with is a little bit of just some key points and then some, I hate to say it, some sobering news. So we have made major progress on under 5 mortality. We know that if we were only looking at 2019 numbers, then more than 5 million children were likely to die that year, or even this year if we were going to extend it. We know that there are known interventions for every major cause of mortality. It's the coverage that's the challenge. It's providing and getting these care strategies to communities that would benefit from them and the uptake of it. And there are opportunities in improving maternal care. We know there's opportunities in female education that has many, many downstream impacts on childhood survival and maternal mortality. We know that there are interventions that can be done through the household and in a community setting and using allied health workers, such as community health workers. We know that vaccine development provides a potential for novel interventions. And then here's the sobering news is that I think, I don't know the numbers and what the ultimate impact is going to be, but we all know that the pandemic is going to have major and long-standing impacts on the health of communities. We know that that's going to impair health systems and undermine the work that they're already doing. And I worry that our trends in reductions in child mortality will be reversed, not only this year, but probably for the coming years until we're able to truly, now I'm going to editorialize, have widespread distribution of an effective vaccine to the global community. I also think that climate change, as we see our skies on fire and filled with smoke, is going to cause climate migration, is going to result in food and water insecurity. And as we talked about, the really important role that malnutrition plays in all of this is going to have potentially a really important and negative impact on survival. And that's something I truly worry about. So on that very happy note, I'm going to stop. I have just a couple minutes left, but if anyone has any questions, I'd love to take them now.
Thank you, Raj. That was amazing. The breadth and depth that you covered that was such a good summary. I feel like I've seen pieces of that, but I've never seen it so comprehensively and thoroughly discussed. Thank you. One thing I did wonder was that trend that you mentioned in Nigeria in terms of the absolute number of deaths. I wonder if it might be more helpful specifically for Nigeria because the population has expanded so rapidly in that country, if the rate might actually be more informative in that situation. That might explain why the absolute numbers actually didn't look like they improved, but the rate may have actually significantly improved. I don't know that. I was just wondering.
No, that's a really important point, and I think that's one of the limitations when we think about looking at only one metric, right? If we only look at absolute numbers, or if we only look at under 5 mortality rates, we're going to miss part of the picture. So I think that's a really good example of that. Thank you, Teresa. I want to thank you all for being here. It's always an honor to be included as a part of this. So thank you, and enjoy the rest of the series.
Thank you. And as a plug, Twinkle put the link for the eval in the chat. All you have to do is click on it. There's literally 2 questions. It should take 1 minute. So we really appreciate your feedback. Thank you, Raj, so much. Have a good day.